Today, we're going to demonstrate accessing and deaccessing a Metaport. We first begin by explaining our procedure to our patient. Perform hand hygiene and apply clean gloves. With our clean gloves, palpate the site to locate your IVAD. Barred power ports are triangular shaped, and you can often feel the 3 palpation bumps on the septum through the skin. This will help you determine the appropriate needle length for the depth of your IVAD. Needles used will generally be 19 to 20 gauge and 3/4 inch to 1 inch in length. The maximum needle length is 1.5 inches, and this is used for patients with larger amounts of tissue covering or deeper ports. To help determine this information, you can check the medical records or ask your patients which sizes have been previously used. Obtain your IVAD kit for inpatient use or your kits and supplies in outpatient. Instruct your patient to turn their head away from the IVAD or ask them to wear a mask. Remove the gloves and repeat hand hygiene. Open your IVAD Access kit or supplies, maintaining sterile technique, and prepare the supplies on your sterile field. Drop your needle onto your sterile field. Don your sterile gloves. Squeeze the wings of the chlorohexadine wand and allow the applicator tip to become saturated. Cleanse the IVAD site 4 inches in each direction for a total of 30 seconds with the chlorohexadine using vigorous multi-directional repeated strokes. We want to allow it to air dry thoroughly without any blowing or fanning. Supplies can now be assembled as you wait for the chlorohexadine to dry. Attach the new caps and prime the tubing and needle off the sterile field with your normal saline, making certain that the sterile field remains dry. Close the clamp on your tubing and return the non-coring needle and syringe to the sterile field. Place your sterile drape below your port. Leaving the needle sheath in place, carefully place the chlorohexadine impregnated disc or the gel pad around the sheathed needle. Begin by removing the film on the gel pad labeled number 1. Grasp the wings of the dressing and hold them along with the flexible wings of your needle. Chlorohexadine impregnated discs or gel pads are not required on ports which are accessed less than 24 hours. If using the BioPatch, the blue printed side should be facing up towards the sky and the white side down against the patient's skin. Hold the sterile needle and syringe together in your dominant hand or place the sterile syringe on the drape. Remove the sheath. Using your non-dominant hand, stabilize the port between two fingers and visualize the center. Insert the needle at a 90-degree angle into the center of the port septum, firmly advancing the needle through the skin in the septum until the needle makes contact with the posterior wall of the port. Open the clamp and verify the correct needle placement by blood aspiration. If you have no blood return, attempt to flush with 5 to 10 milliliters of normal saline and attempt to aspirate again. If you still have no blood return, refer to the IVAD policy for additional interventions you can try to troubleshoot. Should the patient complain of any burning during the normal saline administration, the port is probably not appropriately accessed. The needle may be in the subcutaneous tissue and port access will need to be re-attempted. Clamp your tubing and remove the syringe. Now grasp the white wings at the base of the slit on the gel pad in your dominant hand. And with your non-dominant hand, remove the film by pulling in the film number 2 by pulling in the direction of the arrows. Remove the paper backing on the transparent dressing and center it over the needle wings, making sure that the caps and the clamps are exposed. Do not stretch the dressing because it's designed to return to its original shape and size, and the stretching can cause skin irritation and breakdown from the pressure and the pulling. Peel off the paper around the dressing, smoothing the dressing down securely to the skin as you take it off. Do not throw away the paper backings. It's now time to apply the pants of the dressing. So fold the paper backing to one side and secure the pants down so that the notch is facing towards the patient. Lift the tail of your needle and slide the remainder of the dressing under the tubing. Remove the backing and smooth it out with your fingers. The last part of the dressing is what we refer to as the belt. Write the date, time, needle size, gauge, and your initials on the belt and place it over the site where the two dressings meet. You now have an occlusive dressing. The manufacturer recommends that we go 7 times around the track. So with your fingers, gently put some mild pressure and go 7 times around the border of the dressing. This allows the adhesive to stick more securely. If needed, you can tape a loop of tubing to the chest wall or to the arm to prevent that non-coring needle from dislodging. Remove your gloves and perform hand hygiene. Document the needle gauge, the needle length in the LDAs, and describe the ease of blood return obtained, the patient's tolerance to the procedure, and any problems that may have occurred in the medical record. Report any suspected catheter infections, occlusions, embolization, malposition, or inability to access, and report to the physician at LIP.